Hi, everyone. We are just getting more and more people assigned to the rooms, and then we'll get started. Thanks. Just a few more minutes, and we'll get started. Okay. It seems like we are almost there. A few more people to go for getting into breakout rooms. But welcome, good morning, good afternoon, good evening, wherever you are around the world. We have quite a big group, and we just want to sort of frame the session. I don't know which sessions that you all were in before, but this session is around some of our research hubs. We have two presenters today around the research hub work that is going on across the continent, and really trying to delve into what does partnership look like? What are they doing? And maybe you can link into that. How to start thinking through some ideas that you may have for shared research, for pilot project opportunities, for understanding where you intersect and figuring out how to turn a cool idea perhaps into a research question that perhaps turns into a partnership. So that's the goal of these sessions. It's a really informal session, so please feel free to take yourself off mute when you would like to ask a question. You can put questions in the chat. You can raise your hand on the raise hand feature, and we can call on you. But how we'll focus on this so far is people are muted so far. We are recording, so you will have that later on if you want to see the other sessions that have gone on. So that'll go up on our YouTube channel afterward. And then we'll be able to ask questions not only of the presenters, but also just a dynamic question between the group. So that's the focus of this. Again, very informal. I would encourage you, we don't have enough time to introduce everybody, but I would encourage you to put your information in the chat so we can at least get an idea of where you are, what kind of research you're doing, things like that. So whether that's country, whether that's your institution, whether that's your scientific interest, and maybe that'll help us to spur on good ideas, good thoughts about collaboration as well. So thank you so much to our two speakers, Natalia and Palilani, highlighting our Mediva and our Inform research hubs. Maybe you joined another session prior around research hubs where we were highlighting some of our other centers, but we'll be delving into some of the work that's going on both in Nigeria and across South Africa and beyond. So my name is Brad Newsom. I work here at NIH, and I get to work with this really, really great group of people across DSI Africa, and I oversee our research programs. So while DSI Africa is made up of large research hubs, smaller directed research projects, training hubs, smaller directed training projects, ethical, legal, and social implications awards, and an open data science platform and coordinating center that pulls us all together, I oversee our research programs. So really a wonderful opportunity to highlight some work that's going on that I am personally very, very invested and proud of. So first off, I would say that if you, again, have questions, be thinking about those questions, put them in the chat. We can go back to them. But it would be nice to save some questions until after our discussants talk through their ideas, and then it may spur some other ideas. You can feel free to put questions in the chat while people are talking, but then we'll come back to everybody and we'll have a really good discussion at the end. So without further ado, I will turn it over to Natalia with our Inform program to sort of give us an idea about what our Inform Research Hub is doing, and then maybe spur some questions and thoughts from you all. Thanks, Natalia.
Thank you. So let me share. All right. Hi, everyone. My name is Natalia Blanco. I am a project coordinator for Project One for Inform Africa. I'll be representing Inform Africa today and all its PIs. First, just wanted to give you an overview of the goals and specific aims for the hub. Our main goal is to develop population scale data streams as a cornerstone of future pandemic preparedness. And for that, we're using specifically right now data on COVID-19 and HIV in Nigeria and South Africa. We aim to establish data streams to understand the multi-layer interactions that may explain the dynamics and impact of COVID-19 pandemic through 3 projects and 2 cores, and supplemented by pilot projects, and I'll get back to that. We also aim to develop geospatial tools for the use by country leadership and governments in pandemic preparedness, in collaboration with our industry partner, that is ACROS. And we also aim to expand data science research opportunities through engagement with a broader DSI Africa and through several pilot projects, and maintain a sustained engagement with the policymakers and governments to promote open access to data and redistribution and uptake of any tools or products developed through Inform Africa. So the structure of Inform Africa is really, like I said, made up of 2 different cores and 3 projects. The administrative core is based in the Institute of Human Biology in Nigeria. Its main objective is to coordinate and administer the whole hub throughout all the different projects. The DMAC is the data management core and sequencing core based in Capriza and Stellenbosch University, and its aim is to support the different projects, data management, data sharing. I'll talk a little bit more about each of the projects, but later. But we all work independently and together in collaboration. We're also supplemented by pilot projects. We just selected, I think, 3 to 5 pilot projects that are starting later this year. And then we also work in collaboration with a scientific advisory board that are made up of the PIs and industry and government representatives of the countries we work with and the different institutions that have provided data for our research. And as well, we work with a community advisory board that provides feedback on our work throughout the timeline of the project. And we also work with a ELSI partner, REDSA, that meets with us regularly as well to give us advice. So as I said, there are 3 different projects. The first project is aimed to look at COVID-19 transmission dynamics and risks. And for that purpose, we use different type of data, including COVID-19 surveys that were implemented in both countries during the pandemic, COVID-19 laboratory data, clinical data, sequencing data, and also surveys that were performed during the pandemic to measure adoption of public health measures. And we're still looking into adding other types of data to it. And the idea is to overlap all these different types of data and be able to characterize better and further COVID-19 transmission dynamics, specifically in this context. I'm not able to give you progress for each of the projects, but I'll give you a little bit on Project 2. Project 2 specific aims is to identify whether movement restrictions imposed in Nigeria and South Africa resulting in actual changes to amount, mode, or destinations of travelers using data-driven simulation models, and to quantify the expected contribution of mobility patterns to infectious disease dynamics. I'll give you a little snapshot. This is from a manuscript. I'll put the source here, so feel free to look it up if you're interested to learn more about their methodology or the results. What Project 2 did here was to employ emerging smartphone-based location data and produce daily human mobility measurements, in this case, daily miles travels or daily trips, specifically for Nigeria. Where you're seeing here is a 7-day moving average of that daily miles per person and the percent change across time between January 2020 to April 2020. And they classify the states in Nigeria based on income. So the green is the high income countries, the states in Nigeria, I'm sorry, same countries, and blue are the low income states. You can see both distances show some level of increase shortly after the announcement of the first SARS-CoV-2 case in Nigeria on February 27th, 2020. After that, and that could be explained because people just either panic or, people were trying to go back to their village or, trying to get ready for the pandemic or advance. But you can see in the middle of March, Nigeria banned entry to travelers and they closed schools. And at that point, you can see a drop on mobility, specifically on daily miles traveled. And you can see that across all the different incomes states, all the different income states. So either if you're a high income state or a low income state, they both reduced their daily miles traveled. However, you see the daily number of trips traveled, you can see a difference across the types of states. The high income states travel a lot more, had more trips across time specifically after the federal lockdown at the end of March. Well, the low income states actually travel less or had less trips in comparison to January 2020. Again, this is a quick snapshot because we don't have a lot of time, but feel free to look it up, look at the manuscript if you want more into the methods, want to learn more about the methods or the results themselves. Then for Project 3, the aim is to look at the clinical, epidemiological, and spatial interaction between COVID-19 and HIV. And for that purpose, they're also utilizing different sources of data, clinical data, lab data, surveillance data on both HIV and COVID-19 for both countries. And finally, for our private industry partner, like I said, is Akros. Akros is supporting our goal of describing transmission dynamics of COVID-19 via spatial intelligence. They have developed a tool called Reveal that is an open source tool or platform that uses spatial intelligence to drive the implementation of interventions. And the goal here, they have developed different functionalities within the tool as part of Inform. But also the eventual goal is to incorporate all the data that we have at this moment into the Reveal tool to visualize it and to spatially analyze it. And hopefully later on for it to be used by governments for health intervention implementation and pandemic preparedness. I'm sorry, I went back. And that's it. This is just a few of all the acknowledgements across the Inform grant. Thank you.
Natalia, thank you so much for going through that. I am sure that a lot of ideas are coming up from across the group, whether that's around potential partnerships or perhaps just additional questions for clarification. Again, you can be putting those questions in the chat and we'll come back to them afterward. Really appreciate all of you who have been putting your information in the chat about who you are and what your interests are. Already people are putting some LinkedIn information in there for further networking. Great. You're more than welcome to do that if you want to reach out to people in that respect as well. Victoria? Okay.
Oh,
Okay, so but again, hold those questions, be percolating on them, and then we'll come back to those questions when we're finished with our presentations for the morning. Next over to Pelelani with our Mediva hub to walk us through the work that they're doing in multimorbidity. Pelelani?
Thank you once again, Brett, for the opportunity. Good afternoon, everyone. My name is Pelelani Mbangase, and I am a bioinformaticist here at Wits University with the Sydney Brenner Institute for Molecular Biosciences. So I am part of Mediva as a data analyst, working mainly on Project 2, which I will talk about later in the talk. So just before I dive into the talk, I just wanted to first explain what we meant by multimorbidity. So we define multimorbidity in our group as having more than two diseases in the same individual. For example, you can have your stroke, diabetes, high cholesterol, and so on. So that individual would be said to be multimorbid. So in our group, we noticed that in Africa, there's a rising multimorbidity crisis, as seen in this paper that was published recently with the data from Agincourt, where you see that the number of conditions per individual starting from 2 is about 27%. Is about 32% in individuals from 40 to 49 and so on. And then also, if you look at the different number of categories for the conditions is quite high. So the motivation behind our study is that we wanted to use data science to try and gain some insights into multimorbidity. We are trying to do this by leveraging the available data from health records, from genomic data, from study data, as well as some population information data that is available. So what is data science? So data science is essentially, when you think about it, is like this person doing this high-level programming. But for our group, it's a bit of a challenge because when you look at where the data comes from, it's coming from something like this. So on the left here, you have a clinical record that you get from a clinic. And this is where when the patient goes to a clinic, they have to tick all these different columns in the sheet. And then the data is stored there in the cupboards, and it never gets captured electronically. So this has posed quite a challenge for us because we need to have this sort of data in sort of an electronic record to be able to work with it. So Mediva is mainly led by the Wits Institute, with key partners being the APHRC group in Nairobi, the IBM Research Africa labs in Kenya, as well as here in Johannesburg, SAPRIN in South Africa, as well as the Vanderbilt University. And we are mainly getting our data from those 2 sites, one in Nairobi, as well as one here in Agincourt in Mpumalanga. So we are an interdisciplinary team, comprises of the SBIMB, the Wits Rural, Priceless, Wits Biomedical Informatics, the School of Electric and Information Engineering, Chemical Pathology, as well as Computer Science and Law. So the goals of Mediva, like I said earlier, is that we are trying to leverage the data that is available from these 2 sites that we are working with to mainly try and develop risk models, try and incorporate polygenic risk scores, and as well as precision medicine, and try to understand multimorbidity. We are also trying to develop visualization tools to try and understand the data that we have and understand how data science can be used to support the district level health management, as well as developing novel machine learning techniques. So just to give you an overview of Mediva, so we mainly have 5 sites. So the one is in Agincourt, APHRC, the IBM labs in Nairobi and Kenya, SBIMB, as well as SAPRIN. And we are also working with other partners, LawSA, the Open Data Science Platform, as well as other DSI partners. And the main component, though, of our research hub is that we've got an administrative core, we've got a data management core, as well as the training capacity and development core. And then we've got two main projects, the one being the data integration and visualization, and the second one being the precision, public precision health. So I'm gonna try and explain some of these cores and projects for you, but the administrative, I'm not gonna go into it so much because yeah, there's not really much there to talk about. But the DMEC group, so the DMEC group is, you can call it our core sort of group, because this is where our data comes from. So they deal mainly with managing our data. So they have to design tools as well for linking these different types of records that we're working with, create visualization tools, as well as these dashboards that we want to create for analyzing the data, as well as capacity development, training workshops, and so on and so on. So the DMEC group mainly deals with harmonization of data. As I mentioned, that we've got different types of data coming from different sites. So the DMEC group is mainly trying to harmonize this data, making sure that there are no records that are repeated, no data that is captured more than once, looking at the data that is missing, and also trying to curate basically all the data. And this is where everything that happens in Madiba, the data basically comes from the DMEC group. And the DMEC so far has made some progress. They've finished doing the metadata between the Agincourt and APHRC, and now they are looking at doing the integration. And once that's done, the data is going to be stored on the VOIDS cluster, and everybody who's involved in the Madiba project will have access to that. And I think also anyone who's on their own open data science platform might have the access to the data as well. And then also they're looking at exploring other sources of data sets, for example, the NHLS services. And then in terms of the training capacity development and pilot projects, so we've got pilot projects, we've got training mentorships where we've got our PhDs, as well as the biomedical informatics group, as well as VUMC, and also the ethics and legal training, as well as the translation now capacity. So far, several training courses have been scheduled to run till the end of the year. We actually have another training coming up in October. Yeah, and also we do have some postdoctoral fellowships available, some seed pilots that come up every year, as well as full pilot projects. So far we have awarded 2 pilot projects, one to the Clinical Research Unit of Nanoro in Burkina Faso, as well as the University of Limpopo, the Mamo group. Now, when we're looking at our projects, so the first project I'm going to dive to is Project 1, which mainly deals with data integration and visualization. So what the Project 1 is trying to do is basically trying to link all these different types of data sets that we have, and creating a sort of a dashboard that researchers and clinicians can use to look at the data in their clinics or in the district, at the district level. So far we have been able to have meetings with health officials in Mpumalanga. We've had about 4 meetings so far, and we're sort of trying to get information from them as to what they do on a daily basis. What would they need a dashboard for? What or how can we make their lives easier by creating these dashboards? And we've been trying to do the same thing as well in Nairobi. We've had 1 meeting so far. And yeah, it's still a work in progress with that. And then with Project 2, which is looking at precision public health. So here, what we're trying to do is we are trying to create predictive models that are basically going to take as input the data that we have, and be able to see what, or sort of predict what makes a person to be more susceptible to be multimorbid. So we are using the different types of machine learning models, including auto-stratification. And currently what we're trying to do is we're trying to incorporate polygenic risk scores into the different models that we have. And so far in project 2, we have been doing auto-stratification analysis on the origin data, and a review of multimorbidity has already been submitted to a journal, and we're just waiting for output from that. Yeah, integrating the genomics data as well. So yeah, in conclusion, yeah, Madiva is such an exciting opportunity. We're building on existing work, creating new partnership, and also just looking at strategic directions and skills that we can use in our research hub to understand multi-morbidity. So yeah, thank you so much, Brett.
Palani, thank you so much. Really, really cool stuff going on within your hub. As you can see, these hubs are pretty large, and they cover a lot of different areas of research, but also a lot of different opportunities where you all on the call could potentially link in. Now, each of these research hubs has at least 2 research projects that Natalia and Palani highlighted. Natalia has 3. They have supporting cores around data management analysis, training, administration, all kinds of different areas where they're enabled to do way more than a normal NIH research grant. So that's why these networking opportunities and opportunities for collaboration are so much more possible with these programs. Really appreciate some of you that have been putting information into the chat. We've got information from John about with LinkedIn and some of the work that he's doing, perhaps another opportunity for collaboration and close work there. Definitely check that out. Collins put in some information about the fact that he'll be presenting in room 2 coming up about the data collection work that they're doing across Nigeria. Check that out, as well as CTER. And then let's see, Andrew on the call from OHDSI at Columbia will be presenting in the 3rd breakout session around health data normalization and terminology. That could be a really, really great session for some of you to join, and as well as the work that he's doing with OpenMRS and then primary source for EMR for HIV and public health. Lots of different stuff going in the chat. I do encourage you to keep putting that information in. And Natalia and Palani, if you could put your contact information, Natalia just did. So if you do have questions for them directly, you can reach out to them about some of their work. Now, I don't think that Dr. Shishome or people, anybody from the DSign group, I don't think so. But anybody from the DSign group on? Okay, so with that, we'll jump in to some questions, not only for Natalia and Palani, but about how this all works and how we can work together more effectively. Again, keep putting information in. You've got 3 options. Put a question in the chat, raise your hand on Zoom, and we'll call on you. Just take yourself off mute. This is meant to be an engaged, informal opportunity for networking. So any questions? I want to turn it to you all. I've got some questions for the panelists, but I want to turn it to you all, if at all possible, for you to use this time to not only ask questions of Natalia and Palani, but how your interests may link in. John?
Yeah, so I just wanted to ask, I mean, I've seen a good level of data being used. I want to know how a lot of them, both Natalia and the other colleague, were able to gather their data effectively. What are the process of anonymization? Because I know for the health data, you need to do some anonymization. What are the, pain point and how did you scale that obstacle? Because it's good to learn them. I mean, I've been in and out Nigeria for a good number of time and I've been opportunity to be in some USAID funded projects. So I want to know how they're able to do that now and scale it through, if possible.
Great question. No pressure, Natalia and Palani.
Yeah. So the question is on access of data, correct?
Yes, access of data, then data anonymization.
So yeah, definitely. I think it's definitely a challenge. I think it's one of the things that have took us the first year to start gathering data. Our data sources are mainly governments, government institutions. So I think that makes it another layer.
Okay, so sorry, I have to cut you short. Immediately you said that, from my experience, which I was part of for 5 years in the USAID project, data from the government is 50% correct. I may be wrong. That's 9 years ago, but I may be wrong. I stand to be corrected.
Well, I think that applies to every kind of data, any programmatic data.
Everywhere around the world. So it's not about just.
Well, I think, it is the data that we have available, and we have, I think, also because we have different types of data, we're not only using one specific type to answer the same question. I think the overlapping of different sources makes it more valid. But yes, it's definitely a challenge. From that sense, I think we have made data sharing agreements with all the different institutions to assess the data. They have provided the identified data for the different data sources. Also, in some cases, for example, Project 3 works with Discovery Health, which is an insurance company in South Africa. So they provide healthcare to a big percent of South Africans. So what they do, they have an agreement on not specifically sharing data, but what they do is he provides the queries and they run it for the team, and we get back tables for the results, and that's how we're doing, instead of them sharing the actual physical data with us. So that's a different way. So it's been different for each country, for each institution. But yeah, it's a matter of discussing, and again, a lot of time doing data sharing agreements and requests.
Thank you very much.
Palani, how have you handled this?
Yeah, so I think for us, the one thing that made things a bit simpler was that most of the data sets that we are using, so when they were collecting the data, the participants did agree to having their data being used for secondary analysis. So that sort of makes things much more easier. And we do de-identify our data sets before we do anything with them. So.
Thanks.
Yeah, as you can imagine, John, this is being handled very differently across DSI because we have very different kinds of data sets being utilized, whether that is most, I would say, is secondary analysis. But we even have some primary data collection going on across, and then we have very different ways that we're approaching it now. We are all learning data science, AI, all of these areas are changing so fast right now that we're doing a lot of learning. So Palani's group with Mediva has been working, for instance, for many years. A lot of the work that was going on before was funded through our very large H3 Africa program to be able to do some really, really cool work in that respect too, and then leveraging that moving on. Not everybody had that opportunity. So now, so very different approaches, but you can imagine that we're doing a lot of work around data sharing agreements, how to protect data, how to do not only effective secondary analysis of de-identified data, but then also how do we more effectively utilize synthetic data sets that are robust enough to actually be decisional in nature, to really drive some of our decision-making ability even from a synthetic data set.
makes sense. So
Oh, okay.
the next one I want to push across is, so we were working in a project, in a small project, and I was the consultant, and we were doing something like virtual sensing. And later on, I was thinking, is it possible in health? So virtual sensing is, I'm sure you've heard this report before. You could say, and one of you have mentioned it, you could say, if you live in this area and you have a history of eating this set of diets, you will have 70% chance of having this disease. So that's part of what we call virtual science for some of us that are, AI and data science. So I don't know if have anyone tried it? Did you try? Was there something of such nature? I just want to learn. Meanwhile, we use a lot of parameters, really, so I could expand it. And I'm sure you've heard of it before. So there was a tourist center in Spain, and before COVID, they had issues for tourists to come. And then Google was able to tell them that if you advertise in these 7 specific cities in the world, these people will come for tourism to that area in Spain. And on doing that, that boosted the tourism sector of that city in Spain by 200%, really, because there was targeted advertisement. So that's that model, using that model for virtual sensing. So creating data from a multiple set of data points, not unlike collecting, just like what they said, primary data, so to say.
Well, that sounds like a really good application to put in for developing a new idea. So I do encourage you to think about that. We do have a lot of work from a decision support structure, from Pelani's group is piecing together work associated with a toolkit for decision making. There are a lot of different things from an innovation perspective going on through this program as well. But maybe that's a great idea that you could follow up with people on this call for thinking through what a new idea could be. So thanks for that, John.
Thanks.
Okay, so while questions are coming in, I did want to call on Andy from OHDSI around his question around EHR usage. Andy?
Hi, folks. Yeah, thanks, Brad. It seems that nowadays there's been a lot of progress made in sort of digitizing health records within low and middle income countries. The sort of national health architectures and infrastructures in the public departments of public health are starting to collect data more automatically from clinics. So like OpenMRS is one example, but DIHS2 and others are examples of where primary data collection is now being done either digitally or very quickly digitized at the clinic level. And so I was just wondering whether folks are starting to take advantage of those data sources as they're being made available. And it gets to John's question, I guess, to some extent about aggregating and de-identifying data, but the quality of the data that's at a patient level versus the kind of checklists that I think it was Pelani described as collecting information at the clinic level. Those introduce a whole new opportunity, but also some challenges in terms of data normalization and so on. And so I just wondered if people's in the data hubs and so on were looking at some of these new sources of health information.
So I would love if Natalia and Pelani have any thoughts on this. But again, this is an informal discussion. So if anybody else on the call has some ideas about this and what you're doing, then I would love to hear that as well. Also, Andy will have a session coming up after this in room 3, I think.
5, I think, actually. I'm
5.
not sure.
Okay. Okay. Yes.
We'll talk about Odyssey. Yeah.
But this is a really hot area. We actually just had a meeting of all of our DSI Africa hubs in Cape Town a few weeks ago. And one of our big focus areas was around How do we harmonize? How do we de-identify for more effective utilization of information? How do we use more large accessible data sets? How do we do that in a way that is going to work across an entire continent with very different laws associated with data sharing, data access agreements? There are a lot of things going on, but maybe Natalia and Palani, you could say a little bit about how you're handling that.
Yes. Well, we do have access to the Nigerian HIV surveillance data depository, which is based on programmatic treatment and care data, electronic medical records. The advantage there is that they already did the harmonization from the different sites in country, so it's already at least a little harmonized. I think obviously it is definitely a challenge to harmonize across countries, but yes, it definitely is a very rich source of data, and that's one example. And I think outside Inform, I think we work a lot with treatment and care programs that uses electronic medical records nowadays, and we use a lot of that type of data, and a lot of cleaning and validation has to be done, and especially harmonization, especially if we want to merge different sites, different counties, different programs together, is definitely a bigger challenge. But yeah, I totally agree with you. It's a extremely rich data source.
So it's interesting that I think a lot of the sites in Nigeria were actually using OpenMRS as their HIV system. And I know that the Center for Virology has been a big contributor to the OpenMRS sort of network. One of the things that we're going to talk about in the next session really is that there are ways now to standardize, not just within a health system or EMR like OpenMRS to assert standard codes, but actually to international standards that would allow for interoperability of that data across multiple different sites, countries, and so on. So, standardized codes like SNOMED or ICD and LOINC, and these are all the types of standard codes that would make it easier, at least semantically, sort of to move data back and forth. Not always syntactically, and you have all the sort of data anonymization and privacy concerns, they're all still there, but there is a much more easy way now, I think, to help normalize that actual individual kind of row level data based on those standard codes. So it'd be interesting to see what's in your database.
Yeah, definitely.
Yeah.
I definitely agree. Go ahead.
So I was just about to say that so in our group, we have been lucky to work with Steve Tolman's group in Agincourt. So they developed their own data collection system that it's very extensive, and it's been going on for years. And they've actually implemented it in some of the clinics there in Agincourt, and it's been a bit easier to work with because they do the data check, they do the cleaning, and making sure that even when the people who go out there in the community and do the surveying, they make sure that the data that they come back with is actually clean. So yeah, I think we've been actually very privileged to work with such a data, and they are trying to implement the same type of system also in the group in Nairobi as well, in the clinics there.
Excellent.
Yeah, trying to figure out how we can more effectively share information is often contingent on how we code. And across DSI, for instance, for those of you who are not familiar, DSI Africa involves very different data sets, everything from climate to maternal health, to cancer, to genomic, to surgical care, to GPS-based data, to location associated with the built environment. How do we leverage the built environment? How do we handle transportation networks? So many different areas. And we're trying to figure out how to can't possibly harmonize everything, but we can, in many respects, figure out where the overlaps are to be able to really answer some unique questions. So good luck to all of us. I think figuring out how to do that, that's no small task across the continent, with very, very different ways of collecting data and the different kinds of data being collected. What other questions do you all have at this point for not only our presenters, but within our hubs, but then also just across any questions that you may have that some people on the call may be able to answer or have thoughts on? Again, you can put questions in the chat. You can raise your hand on the raise hand feature, or you can just unmute yourself. While you're thinking of your questions, maybe we can, again, this is meant to be a networking opportunity because our research hubs have a lot of opportunities within each of their hubs to expand. And before I get back to you, John, it would be nice to just know from the standpoint of our research hubs, what kind of partnerships are you interested in? Maybe what are you working on that you really would like to have a new opportunity, a new data set, a new expertise, anything that you're really looking for in partners, or also that you would like to potentially partner with somebody on a pilot project for. Any thoughts, Natalia or Palani?
Sure. I think for us, we're interested in expanding right now. Like I said, we're focusing on COVID-19 and HIV, and specifically Nigeria and South Africa. So I think we're definitely interested to expand to other countries and other pathogens as well, to look into transmission dynamics. So I think that opens up the door to a lot of things. So yeah, feel free to reach out.
Yeah. Natalia and Pelilani's information is in the chat, so please feel free to reach out to them. I'm not encouraging you to spam them, but I sort of am. So, Pelilani?
Yeah, I think for us, it's mainly being able to use the genomics data through these machine learning models. So finding a way, or I don't know, the type of features in the genetic data that can be used in terms of machine modeling and or, auto stratification. I think that's where our, say, weakest point is at the moment.
Yeah, and if some of you on the call have ideas around that, this is all about partnering. So reach out to Pelilani if you do have some thoughts on that. I do want to say that we have 5 minutes left, so we just have a few opportunities for a little bit more conversation. I do want to encourage you that these are being recorded and they will be on the YouTube channel later on, so you can either follow up, you can see something that you may have missed, or you can see the other sessions that you are not able to see because you're on this session. So encourage you to look at that. Also, Sakanat asked if you could give slides. I cannot, but you can reach out to the presenters directly if you are wanting a specific slide. Again, you'll be able to see the slides on the video, but if you're wanting specific information, reach out to the presenters today. So, Andy has put in some additional information around OpenMRS that may be a benefit to you all. And encourage you, there are a couple great sessions going on right after this. We've got 2 minutes. John, do you have something that we can handle in just a minute? John, you're muted. Doesn't look like you're muted, but we can't hear you.
Can you hear me?
Okay, we can hear you now.
Oh, okay. So I wanted to say to Peloni that we could create features from the genomic data that could be used, and I mean, I think I'll get back to him because we've done that for some primary healthcare scenarios and data in some part of central Nigeria and Cameroon, northern Cameroon, and I think it could be scaled too.
Great. This is what these networking opportunities are all about, making connections. So this is a great example of that. John, I hope that you do reach out to Pelilani about that. Okay, we are at the end of our time. I do look forward to seeing some of you maybe in another session, but again, please feel free to reach out to people over time and keep this networking going.
Thank you.
Thanks so much, Natalia and Pelilani.
Thanks, Brad.
Thanks, Bragg.